Hello, I'm Jack Cush with the Baylor Research Institute. Today we're going to talk about adult Still's disease. I'm going to start off talking about the history of adult Still's disease. I figure what better way to start than with a patient. This is the patient I actually saw in 1983. TR is a 23-year-old white female admitted to the hospital with a 5-day history of fever, rash, and a sore throat. She complained of daily or sometimes twice daily fevers up to 104 degrees Fahrenheit. The fever was always preceded by the chills. She had a red rash over her trunk, neck, and arms. She complained of diffuse myalgias, wrist pain, and 3 days of abdominal pain and diarrhea. Her sore throat had been going on for 2 weeks. She had gone to her primary care doctor who gave her penicillin, but she developed a rash and the penicillin was discontinued. When you looked into her past medical history, she had a history of rheumatic fever at age 9 and numerous hospitalizations between the ages of 9 and 12 for several diagnoses, including rheumatic fever, arthritis, FUO, fever of unknown origin, and hepatitis. The review of systems was otherwise negative. During her hospitalization, she had lymphadenopathy, an enlarged spleen, hepatomegaly, pleuritis, and pericarditis. Her white count rose from 20,000 to 40,000, and she had elevated liver enzymes. On the right, you can see that she had fusion of her wrists. So this is a gal who actually had juvenile onset systemic disease or systemic onset juvenile arthritis, SOJA, but now it was recurring as an adult, and we call that adult Still's disease. You can see here her fever pattern with spiking fevers going on initially, and then once she started on steroids, that the fevers became less frequent and less prominent. So this is defined as a systemic inflammatory disorder that affects kids and young adults, usually up to the age of 35. It is notable for its quotidian fevers, daily spiking fevers, an evanescent rash, arthritis, sore throat that starts at the beginning of the condition, serositis, organomegaly, leukocytosis, and an exuberant acute phase response. There are no diagnostic tests or serologic tests for this condition, hence it is a diagnosis of exclusion, and hence it is a syndrome. It is a condition that is notable for its systemic exacerbations with high fevers or chronic arthritis, often with long disease-free intervals. When you compare this condition in the adults to that seen in the children, you can see that they're pretty much the same. This is a listing of the variants of juvenile arthritis that are seen, and on the bottom is the systemic variant. This makes up 20% of all children with the onset of arthritis. You can see it usually happens between the ages of 5 and 16 years. Males and females are equally affected. They tend to be ANA and rheumatoid factor negative, and they have the exact same manifestations as that seen in the adults, with fevers and rashes, serositis, organomegaly, high white count sed rates, CRPs, ferritins, and a chronic anemia. When you compare adults to the systemic onset JIAs as shown in this slide, you can see that pretty much have the exact same manifestations across the board. 90+% have the spiking fevers. 90+% will have the evanescent rashes. 90+% will have the arthritis, which is usually a polyarthritis. The prodromal sore throat is something that distinguishes the two. Very common in adults, about 70–75%, whereas in kids, it's only about 15%. As you can see, even on the bottom, the genetics are roughly the same. The bad part about this condition is it does run the risk of developing a chronic severe arthritis, which can be erosive and damaging in up to 1/3 of cases. This is George F. Still. This is a picture of him, and this condition bears his name. It's because in the late 1800s, George F. Still, who was working in England at the time, described a set of children who had this condition, many of whom had systemic features, including the fever, the lymphadenopathy, the anemia, and whatnot. He did not describe the rash. And again, a lot of what was considered in his 22 kids was that of just simple juvenile arthritis of the Pauci and polyarticular type. But a subset of those 22 actually had this systemic variant that now bears his name. The history of this condition actually really starts in adults in 1971 by this seminal paper from Eric Bywaters in Annals of Rheumatic Disease, wherein he describes 14 females with this condition, and they had what was later known to be adult onset Still's disease. But even before 1971, there actually have been numerous reports of Still's disease in the literature. Going back to 1896, Bannatyne and Chauffard actually described described patients with a systemic onset to their rheumatoid arthritis, meaning they had fevers and lymphadenopathy and splenomegaly and anemia, and that's what distinguished them. Again, in 1897, George Still describes 22 patients with Still's disease in kids, and a subset of those had the systemic variant. In 1933, there were reports in the literature of the Still's rash, this evanescent rash being described for the first time. And then Otto Moltke in the Scandinavian Journal of Rheumatology describes Still's disease in adults also in 1933. If you look in the French literature in 1943, they had a similar syndrome that was called subsepsis hyperallergica, or the Whistler-Fanconi syndrome. And these are patients who really also have Still's disease. But again, the condition takes off in 1971 with Bywater's description of 14 females with an adult onset of this disease. And then in 1973, Joseph Bujak and colleagues at the NIH described 10 males, all young, all with the same disease and its systemic manifestations. I think the next big benchmark was in 1976, Tom Metzger and Wallace Christie described the association of carpal ankylosis with Still's disease. That's a brief history of this condition. You can see by the publication reports shown here that there was very little in 1971 and 1975, one or two reports a year. Now in 2012, we're seeing on average about 60 to 70 new reports of adult Still's disease, and a much greater number if you talk about Still's disease in general that includes children. So this has become a very popular condition. It's a common test question on medical board exams. It always is brought up in any patient who may have fever and arthritis, and the diagnosis is still uncertain. You can see from this graph that there really is a worldwide distribution. This not only affects males and females equally, this affects pretty much all races in all countries. So this could be considered almost in every corner of the United States. How common is this condition? That's shown here. You can see that in the top half, the number of Still's disease cases per year is roughly 1 to 2 cases a year in most major medical centers that have been in the literature. In the bottom half, you can see the percentages in which Still's disease makes up the proportion of patients with fever of unknown origin. In large cohorts, 200 to 400 patients described with fever of unknown origin, what percentage of those actually have Still's disease? You can see it's consistently somewhere around 5 to 6% in many of these reports, which makes it the #1 autoimmune cause for fever of unknown origin. In fact, if you now look at the epidemiology of this condition, this is a rare condition with an event rate of somewhere between around 0.16 cases per 100,000 patient years. That means that in Dallas, Texas, where I live, we might expect to see around 19 cases per year. So it's not that rare. It will occur in most major medical centers about 1 a year in the least. To end, we could say that this is a leading autoimmune cause of fever of unknown origin. It does cause considerable morbidity. It generally is not a condition that kills people. It just causes a lot of discomfort, a lot of disability. There is a large need for very aggressive therapies, including high-dose steroids. The management of the disease usually involves the use of immunosuppressive and biologic agents. It is costly. It is a diagnostic challenge, and often the treatment is not that clear to those who don't see many of these patients. These patients over time will require frequent hospitalizations to diagnose their condition or to manage their fevers. Weight loss can be a problem. It can be complicated by the macrophage activation syndrome, a very serious complication. And again, somewhere around a third of the patients will develop a severe, erosive, if not deforming arthritis. Hence, this can be a real diagnostic challenge. In our next segment, we'll talk about the manifestations of Still's disease.